You may know FUJIFILM as a trusted leader in endoscopic equipment, but we have recently evolved to become a complete endoscopy partner from screening to treatment for all kinds of endoscopic procedures. The acquisition of the endotherapeutic device manufacturer Medwork, now FUJIFILM Medwork, has significantly increased the width and depth of FUJIFILM's portfolio across the endoscopy pathway. For procedures in the upper gastrointestinal tract, which includes the esophagus and the stomach, FUJIFILM offers its latest series of gastroscopes. They have excellent image quality, including multi-light technologies which incorporate LCI and BLI imaging modalities and enhanced optical magnification for improved detection and characterization of abnormalities. Even during challenging times like the COVID-19 pandemic, FUJIFILM is continuing to innovate, helping to ensure safe and efficient procedures. Unique solutions such as ultra-thin endoscopes to perform transnasal endoscopy help to reduce patient backlogs while maintaining an excellent image quality. With a vision to become a complete endoscopy partner from screening to treatment, FUJIFILM now also offers a wide range of therapeutic devices and endoscopic ancillary devices which enable physicians and nurses to perform a wide variety of procedures utilizing FUJIFILM's innovative technologies. Solutions for hepatopancreaticobiliary, such as ERCP procedures, are also redefined. From special endoscope features supporting guidewire-assisted cannulation all the way to stone extractions and other challenging procedures. Small bowel procedures, such as enteroscopy, require specific equipment to reach deep into the small intestine. FUJIFILM's proprietary enteroscopy solution utilizes a specialist endoscope with double balloon technology, the gold standard in performing enteroscopy. It enables the physician to reach deep into the small bowel to perform diagnostic or therapeutic enteroscopy, supported by FUJIFILM's new therapeutic device portfolio. FUJIFILM's expertise and continual innovation is reflected in its solutions for the lower GI tract, starting with the unique CAD-EYE system, supported by FUJIFILM's deep learning AI technology Riley, which enables computer-aided detection and characterization of polyps in the colon. When detection and characterization is successful and CAD-EYE has identified a polyp, for example a neoplastic lesion, resection can be performed utilizing FUJIFILM's endotherapeutic solutions. For more information, get in touch with us via our website, fujifilm-endoscopy.com/contact. FUJIFILM, value from innovation.
Good evening, dear colleagues. I would like to welcome you to our webinar, ESGE webinar, sponsored by FUJIFILM. The title is From Screening to Treatment, and we have three excellent speakers presenting us very interesting talks on different subjects. We have, for example, Erik Schoon from the Netherlands. He's talking about endoscopic imaging. And we have Roberta Maselli from Italy showing us how to treat upper GI lesions. And we have at the end Dr. Edward Despott, and he's showing us a new treatment of bird bumper syndrome. So I think we have a very exciting program. So we can welcome everybody here. And it is important that you all can ask questions in the Q&A box. So I would like to motivate you to ask questions to all the talks, and we can discuss this after every talk. So Erik, I would like to welcome you to give your talk on endoscopic imaging of the upper GI neoplasia and the potential role of BLI and LCI. Erik, please.
Thank you very much, Mr. Chairman Oliver, and ladies and gentlemen. I'd like to thank FUJIFILM as well for the opportunity to give a talk on the endoscopic imaging of upper GI neoplasia and the potential of BLI and LCI. So these are my disclosures. When we look at the imaging modalities available throughout the world, the majority of them is from three brands: Olympus, who provides the white light and NBI and near focus endoscopes as electronic chromoendoscopy. Pentax has iScan 1, 2, and 3, and FUJIFILM has white light and FICE, but since a few years also white light endoscopy with BLI and LCI, combining with Zoom trimodal imaging. So to these imaging modalities, you can add endoscopy as well by using acetic acid, Lugol staining, or indigo carmine, and you get even more possibilities. I can show you some examples today. So if you do optical chromoendoscopy, the narrowband imaging is a pre-processing technique from Olympus. And we have the FICE and the iScan, which are post-processing techniques. So the light is being, output is being processed by computer to improve the image. So the new FUJIFILM Eluxio system is with blue light imaging is a pre-processing technique and creating these images we just can appreciate here in this image. So it contains of a CMOS technology and 4 LED multi-light technology, which gives the very bright and clear imaging. So what are the clinical applications for the electronic chromoendoscopy? So we can use it, in fact, in every organ we work with, in the esophagus, the stomach, the duodenum, the small bowel, the colon, and their miscellaneous situations in rare conditions. So in the esophagus, we can very well see Barrett's and dysplasia, early cancer, try to find squamous cell dysplasia. We can use it in minimal changes, esophagitis and esophageal esophagitis, and for the stomach in intestinal metaplasia and early gastric cancer and polyps and Helicobacter pylori infection. And for the other organs, there are several indications, but tonight I will focus on the esophagus and the stomach in my lecture. So another question is, how often is digital chromoendoscopy used in clinical practice? And for that, we did a questionnaire study at the Dutch National GI Training Symposium. And we asked the gastroenterologists and GI fellows, how often do you use an imaging enhancement technique in clinical practice? And 80% of the experienced gastroenterologists did. And of the GI fellows, surprisingly, only 50% of them ever used digital chromoendoscopy, probably because white light was still difficult enough. But still, there's room for improvement there. And furthermore, we asked them about if they had a possibility, so go one slide back, to save HD quality images or HD quality videos and images in the electronic patient file, and that did not reach 100%. I mean, and as a teaching possibility, the best teaching you do yourself. If you make an image, get the histology, go back if you don't understand, and that's a huge opportunity to learn. So I give some clinical examples. In this case, a patient is sent with high-grade dysplasia on a biopsy for what's supposed to be a short segment Barrett, and in retroversion we find that the majority of the lesion is below the Z line located in retroversion, and so we switch on LCI and we switch on NBI. And by that, we have 3 possible ways to review the abnormality and to make up our minds. And if we then focus on that yellowish area with NBI, and we do 2-step zoom, we get this image. And what do we see now? I mean, it gets a bit more complex if you zoom, but it can give a lot of information as well. So what we see on the lower part, we see normal tissue, and we see a normal gastric tissue, and that's expanding into a hyperemic zone. It's getting dark, the hemoglobin absorption by the 410 nanometer of the BLI. And we see hyperemia, and on that upper border, we already see vascular changes. And that's the way cancer develops. And cells are growing so fast that they become necrotic, and you get a necrosis layer above it. And if you flush it away, you'll find an area with completely unorganized vasculature, and that means this is definitely a cancer. So first, we detect it. Secondly, we characterize it. And thirdly, we made a delineation in this case. And then people would ask, do you take a biopsy? No, we don't in this case. Or we take one, and I'll show you which. This patient has been sent with high-grade dysplasia. We already know there is, and where smokers is fire, and this is probably cancer. So what we do, we take one big biopsy, in this case an ESD, and it's the final step in diagnosis and the first step in the treatment. And this showed to be a PT1A, M3, and G3V0 carcinoma, and we did an R0 resection. So, but the ESD, I would like to call upon Dr. Maselli, because she's going to show you that in much more detail. So, why could chromoendoscopy contribute to the diagnostic process of early cancers? And I already showed you the clinical example. So in detection, early cancer has some main features compared to the background mucosa. We see subtle color changes, usually through the vascularization. So we have a tumor gets angiogenesis, and angiogenesis gets more blood, more red, or more dark in case of BLI. And we get surface irregularity, and the surface irregularity is also expressed more in chromoendoscopy, and as well superficial necrosis, as you saw. So there are also doctor-operated related aspects. So if you do a trimodal imaging, or you use other image modalities, you probably enhance other aspects, but also you see the lesion 3 times. And that means you have 3 possibilities to find it. And it can also be combined with other electronical or vital chromoendoscopy, for instance, acetic acid in case of doubt, or Lugol staining in case of squamous cell carcinoma. You're not certain if there's dysplasia or not. So then we can characterize the lesion. Is it normal tissue? Is it a tissue? Is it inflammation, or is it dysplasia? For instance, tumor residue post-treatment in a large colony, ECMAR, etc. The chance of a recurrence is still 15% or more. And we can, in delineation, accurately identify the borders of a tumor before therapy, so that we definitely can remove the tumor en bloc, which is in a great benefit of the patient, as well as the organ-sparing therapy, which we were able to do since a few years. So the subtle changes indicate dysplasia or early cancer. And for instance, texture, we analyzed images for what is cancer and what is not. And then we can see that dysplastic tissue shows a higher variability in texture compared to non-dysplastic tissue, which is very clear. And if you take the time to inspect and to inflate and to clean, especially, and have a good endoscope, you definitely going to appreciate these abnormalities. So a novel chromoendoscopy mode is introduced at the market. But how to study a novel chromoendoscopy mode? How it contributes to the clinical work and has something to add? Well, that's definitely a complex research. It's usually done on images and not on video. It's usually on expert's opinion, and a high definition white light already contains a lot of visual information. You also are looking at sometimes at relatively rare diseases, upper GI cancers, Barrett's cancers, and early gastric cancers are not very prevalent in everyday's clinical practice. For instance, lower GI colonic polyps, they are much more prevalent, and they're somewhat easier to study. Also, different modes can be used for detection and characterization. And most studies have focused on predicting neoplasia on zoom images. And what even most important is, how do non-experts perform? Because that's the people who do the majority of the clinical work. So one of the studies I would like to show you, this study from Jeroen de Groof, supervised by Jack Berman, and our chairman of tonight, Oliver Pech, was also in the study group, and that studied if blue light imaging had additional value to white light endoscopy. And two features of optical chromo endoscopy were studied: the assessment of the lesions in overview, the surface irregularities and macroscopic inspection, as well as the visualization of the demarcation line between healthy and cancerous or dysplastic tissue. And that's comparing to the delineation prior to an endoscopic resection you will show shortly in the next presentation. So the data acquisition was done with the Elixeo system, 40 patients with a visible lesion from three tertiary referral centers in the Netherlands and Belgium. And so here we see 40 the corresponding overview images were applied, and here you see two of them in white light and BLI. Also 18 corresponding magnification images from 2 per patient were added. They were assessed by 6 international experts with an online software tool for evaluation and delineation of the images in 3 assessment phases. Assessment phase 1 was white light images only. Assessment phase 2 was BLI images only, and assessment phase were the white light and the BLI images combined, with both in one view seen by the assessor. The questions that were: how well can you assess the surface relief and overview in VAS scores? How well can you delineate the lesion? And what's your preferred technique for delineation? What's in the score? And this is an idea how that worked, and everyone gets its own color. So you see there's a little bit difference in the delineation process, even in experts. The conclusion of this study was: experts appreciate BLI better than white light for visualization. The surface irregularity and the demarcation line were well in view, and experts preferred to use BLI for delineation. Overall, quantitative agreement for delineation did not increase with BLI. And that may respect that there are already very high quality white light images, and also that experts well, probably have enough or can do with really good white light images, because they used to find lesions. But the agreement between the experts did increase with BLI for lesions that were hard to delineate with white light alone. So there was some difficult lesions, and they were quite different. And furthermore, there was a significant benefit for white light and BLI for lesions that were hard to delineate. And in that case, you can see here, if you see all the colored lines, that the inter-observer variability between the 6 experts was much smaller in case they used both modalities together. And that was significant. So the implications for clinical practice is that BLI, next to high definition white light, can aid endoscopists with a better visualization on surface irregularities and delineation. And especially when you have a hard to visualize lesion with white light alone. And you see on the right panel that the BLI, it's definitely much more easier to recognize in this case. So another publication from this group was about adding the blue light imaging and link color imaging adding the link collagen imaging to kind of same type of research. But in this case, all this was compared to non-expert endoscopists. So how do non-expert endoscopists appreciate the BLI and LCI? As we've seen that, that the BLI by expert is appreciated and has some advantage. And 76 non-experts were involved in this field. And here you see the experts on the above left panel and the assessors on the lower panel. And they did not bad at all. Because of the good quality of the images, of course. And so in conclusion, the use of BLI and LCI improves the visualization of the Barrett's neoplasia when used by non-expert endoscopists. And assessors appreciated the addition of BLI and LCI better than white light alone. And this addition led to improved delineation performance and a better area where should be biopsied. So I give some clinical, what about the stomach? I give some clinical examples. So here we see a nice antrum with the pylorus. And if you look well, there might be some whitish discoloration, and with LCI this is getting more pronounced, and so you can see that this patient really has a severe intestinal metaplasia of the stomach. And if you find a patient like this in clinical practice, I always look very carefully, because here you are going to find your early gastric cancer, which in this case was true. Here you see the lesion on white light, and it's bleeding a little bit, it's a little bit elevated, but not too much color difference. So if we look at BLI, we can see in fact the delineation. Where does the healthy tissue stop? It's a little bit elevated because cancer tissue used to grow beneath healthy tissue, and that's one indication. And again, the BLI expresses the blood. So if we see LCI, which was a former also seen by a previous set of endoscopes, which was used in Japan, and they said, well, if you want to find the early gastric cancer with LCI, you have to look at pink and purple as a pink area within the purple, and that's exactly what you see in this tumor. It's bleeding. It's a T1 carcinoma. It has been removed successfully. And also if you use the zoom, you can delineate here. And so a study was performed with the same group from Amsterdam on the supervision of Jacques Bergman with a group of Japan with Professor Yamamoto, and they did a comparable study on gastric images, and it was published in this year's Surgical Endoscopy. So this was the setup of the study. Again, assessment by 3 expert endoscopists compared to 26 non-expert endoscopists, and with 40 cases in white light, LCI, and combined. And the conclusion of this study was that the addition of LCI to white light improves the visualization of the early gastric cancer, and experts reach higher consensus between neoplasia and inflammation when using LCI, but also non-experts improve their target biopsies by the use of LCI. Therefore, it appears to be a useful tool. So another clinical example to end. This is a gastric lesion, and we often get lesions referred, and we often find 2 lesions in the same person, and it can be a Barrett's cancer combined with a gastric lesion, or 2 gastric lesions, or several lesions in the same Barrett, or even more squamous cell carcinoma. But if you have a white light image here and the BLI here, you can see, and appreciate the lesion, but you can also see that there are more spots of intestinal metaplasia, which he probably didn't appreciate only with the white light imaging. And LCI is really lovely for this lesions in the stomach. And if you look a little bit further, you also find the second lesion here, and the large lesion contained high-grade dysplasia, and the small lesion, low-grade dysplasia, they were removed in one session. And here you see both them on LCI. We didn't talk about other aspects of the chroma endoscopy, and that's one of the anatomical landmarks. I will show you. Not many of you are familiar with palisade vessels, I presume, but here you see a neoplasia in the esophagus. But the palisade vessels run from the esophagus down to the gastric folds, and they dive under the gastric mucosa, which is thicker. So this area is absolute the area where this is definitely the end of the esophagus and the beginning of the stomach, and that's especially useful. Can be useful in patients with AHD. One other aspect I'd like to tip upon is that LCI, I prefer to use it in endoscopic therapy as well, because it gives a lot of light. You can see it very clear, and you're not bothered by vision by blood. You can also combine like this white light with LCI and acetic acid, and then you definitely can see here the loss of acetic acid whitening. Here you see on the right side, you see wonderful intestinal metaplasia, which is absolutely healthy. And then here is a carcinoma. Why is it a carcinoma? Because here you can see on the lower part of the image that it's growing beneath the squamous epithelium. So that's per definition invasive tissue. So that's the way we work. As my colleague Wouter Curves, which I on a daily basis do a lot of work with, and this is Jeroen de Groof, that's one of the investigators of the AMC, and who from which the study was I presented. In conclusion, ladies and gentlemen, Mr. Chairman, chroma endoscopy, BLI and LCI are a relevant addition to white light, have several indications, have impact on clinical practice, presumably influence clinical outcome as well, although they're not studies, it's not scientific proof of that. They're definitely underutilized, and I think training is and practice is mandatory. Thank you very much for your attention.
So thank you very much, Erik, for this great presentation. I think you showed us that the new Fuji system, the Luxia system, is giving us really excellent images and image quality and different features to really detect and delineate lesions. I think we directly go to Roberta Maselli. She's an excellent endoscopist from Milan, Italy, and she will talk about the treatment of upper GI lesions, why, when, and how. Roberta, please.
Thank you. Thank you for this introduction. Thank you for FUJIFILM for having me here. And thank you to Erik to shown us how important was the impact of LCI, BLI, and the chroma endoscopy in the diagnosis. So we will move now to the treatment and what's the EndoSolution for upper GI. I will try to answer to these three main questions. So why, when, and how to treat the lesion that with the diagnostic part we are able to find. So the basic is that we are talking about superficial endoplastic lesion, and we know that the endoscopic appearance is the most important because they make the suggestion that they are still superficial and they are not going deep in the muscular layer. And this is why, again, diagnosis and the chance to have a real tool in our hand is so important. But the upper GI endoplastic lesions are very different depending on, we are talking about different organs. In the esophagus, we know that we can talk about dysplastic area and carcinoma on Barrett, but also coming from squamous cell epithelium. In the gastric side, again, dysplasia and early gastric cancer, but also we have the duodenum and the small bowel. I will focus on duodenum because it's the upper GI up to the trace ligament. And again, here we can have adenoma and in some cases also early adenocarcinoma. So the first question was, why are we treat those lesions? And the answer is very easy, because all of that, they will progress to cancer, from LGD to HDD to finally intramucosal cancer. And we know this is again from the diagnostic part that we have some architectural changes that then definitely means that in our endoscopic endoscopic image, we'll notice something different. And then when we took a biopsy, we'll find that in histological reports and fragments, we have those changes in the cells. So the progress of cancer is differently also here, depending on the tract we are considering. If we look, for example, among patients with Barrett esophagus, the progression to esophageal adenocarcinoma differently from LGD to HDD. And the same thing is for the squamous epithelium in the progression to the superficial carcinoma. So the main things that is coming from this data and also from other data, the progression of cancer from the gastric side, from atrophic gastritis till mild to moderate dysplasia, and also in the duodenal part, is that all of them for sure, they will arrive with time to cancer. And this is why we have to remove all of them. So the question to the second one is very easy. I will come there in just 1 or 2 slides, but you already can guess it. So the answer is always when we found them. So we have to find it. And this is why diagnosis is so important. And if we come to this update 2022 of the endoscopic ESG guidelines from the ESGE, we said that to answer again to this question, when to treat them, we know that the pre-treatment diagnosis and assessment is one of the most important things, because we don't find the lesion, we are not able to remove it. So the answer here again is a very easy, always when we found it. But then let's arrive to the critical part. So we found the lesion, we understand and we have to remove it always, but then how to treat it? And also here we have different things that we can do. But again, the basic principle is that we are talking about oncological endoscopy. So our goal is the oncological radicality. That means air view resection with negative vertical and horizontal margin. That most of the times it means en-bloc resection. But we know that we have some lesion, mainly in the colon, not in the upper GI, and we'll talk also about this one, where we could apply not an ESD, that is a little bit complicated procedure, but EMR, that in some cases also is enough to do it in a piecemeal fashion and not for sure in en-bloc. Everybody knows the difference between EMR and ESD, about the training, about the tools, but the main difference is the size and the type of specimen that we are sending to our pathologist, and then the pathologist report that those people are able to give back to us. And if our goal is the radicality, the only way to go in most of the cases is for en-bloc, that means ESD. Coming back to the guidelines and focusing on esophageal squamous cell superficial lesion, we know that all of them, they should be removed with ESD. And what about EMR? We know that we have mainly 4 types of EMR: the injection-assisted, cup-assisted, ligation-assisted, or this cold snare. Nowadays is really the hot fashion and everybody wants to do the cold snare, but in some cases it could be accurate, and we'll see which cases. We said that in the esophagus part for the esophageal squamous lesion, the ESD is the gold standard, whereas it's very different for Barrett esophageal associated lesion. In most of the cases, the band-assisted EMR is acceptable, and then we should go for the ablation of all the Barrett's mucosa that is remaining there after the EMR. But then just for when we have suspecting a superficial SM invasion, we should go for ESD. And let's see some videos, because when we talk about treatment, we should understand as endoscopists what are we doing and what are the options that we have. This was a long Barrett with this wide area that we were making the diagnosis before, so I'm not focusing on the diagnosis. It was the other relation, otherwise we won't have time to see all of this. And after marking, I'm using a flash knife from FUJIFILM that helped me in giving a very precise cut in and just around my previous marking. And with the flash knife itself, by syringe with my assistant, I can flash it, and this is why the name is flash knife, and inject in the submucosa. And with the cup very easily in the esophagus, it's not so difficult, because for gravity, the gravity is helping us to enter in the submucosal space. You know that in third space endoscopy, we are creating a new space that is the submucosa, that usually is a virtual space, by injecting by a solution. So we are, via the same knife, injecting and entering the submucosa. When we encounter some vessels, we can coagulate with the tip of the knife, or if they are a little bit bigger, with some coagulation grasper. And again, coming back in the luminal side, we can inject through the mucosa and keep on cutting and making the mucosal incision just around our marking, and try to remove, and this is our goal, this lesion in en bloc fashion. So step by step, I will use the cutting current with a flash knife. I want really to highlight how this cutting is precise and give you a nice cut of the exact point you want to cut. And then these are the final external and lateral part of the lesion. We will be able to remove it. In this particular case, we applied a clipping line traction, because in the esophagus it's very easily that it will fall down while you are cutting for the gravity. And then finally, we were able to remove it en bloc. In the early gastric cancer, again, the guidelines said that ESGE is the most important things to do, because we have to remove that lesion en bloc, but we should consider EMR only for very small lesion, less than 10 millimeters, just in case we know that they are fitting inside our snare. So I want to show you this patient that I've done yesterday, and here we're using again the flash knife, both type, but also the EST hood. This is this special hood from FUJIFILM that has this specific and dedicated shape to let you easily enter in the submucosa. And later on, finally, I applied also the Purastat gel, that is this peptide, the transparent gel that helps you in preventing delayed bleeding. Also, I use this Manta needle, that is a special needles that has a conception really different from the conventional needles that we have in our unit, because here the injection luminal site is very wider than usual in conventional tube. And this means that with the same size, you are able to easily inject throughout the needle. But let's see how all those things that I show you, they are working together in real time, in real life, I mean. So this was a high-grade dysplasia in the gastric side nearby the pylorus, but the patient has two lesions. One was very small, was a 6 millimeter, and the other one was nearby the pylorus, around 15 millimeter. So with the flash knife, I was able to mark the lesion. And here we are, the two lesions. Then I was focusing on the bigger one with the Manta needle. I was easily injecting in the pyloric side, that is the anal side, because we have to think about gravity and how will the lesion react to our cutting. And after made the first mile, I will just make a small trimming to not real enter, but to start removing those fibers of the submucosa nearby my cut. As you saw, I was flashing throughout my needle. But then when I came back to the oral side, I inject again with the Manta, and I did the same. So another smile, searching for the submucosa, and then submucosa dissection. Most of the time I can just flash it to clean my lens, but also inject in the submucosa and create the safe cushion. And then step by step, just applying the current, because with this cap, it's easy to go under the submucosa. I'm removing the lesion in one piece. That was my goal. And the other one, the 6 millimeter lesion, I use this cross snare to easily cut in one piece. And finally, I apply the Purastat to prevent the bleeding. I will go, otherwise we don't have time to show all the things and say all the things I want to say. The things are a little bit different in the duodenal lesion because we know that in this side, closed-nair polypectomy for smaller lesion or EMR in general is more acceptable than ESD. That is very difficult and complicated. This is why also from the guideline ESD is not recommended routinely, but mainly also hot EMR is a little bit tricky in this part of GI because there's a high morbidity for bleeding and perforation. And this is why most of the duodenal lesions are performed in expert centers. And nowadays, we are talking about closed-nair EMR and underwater EMR to have a same success rate, but a lower rate of adverse events. So the question and the debate is always that one. So let's go for hot EMR or for cold EMR. You know that we have some snares from Olympus that can help us in deciding just when we are inside the treatment is to apply the current or not, because the snares are working with the hot or with not. That is the cross snare. That is why we call it a hybrid snare, and you have 10 or 15 millimeter. But then we also have the cross snare 0 that is dedicated, very stiff, only for zero resection. That means without thermal diathermy, but just with cold snare. And for example, this is what I've done 2 days ago. Is a small lesion, I know, but I'm looking for a diagnostic part. Again, I want to show you that one. I use the manta needle to inject it and to elevate and expose the lesion to my vision. Otherwise, it's difficult. And using the cross snare 0, this was a 12 millimeter snare. I'm easily able to catch it partially underwater and remove it and block. It seems that it's bleeding a little bit, but with the cold EMR is usually this one. The fact is that we can apply the same also for piecemeal, big and wider EMR in the duodenum with really a low rate of complication. So in conclusion, to ask and to answer to the 3 main questions I had in my presentation. So the first was why is the progression of cancer? So it's very easy to answer. The second was when, and the answer is always, but we have to find it. And finally, how? So I said that we have different indication. That means different techniques depending on indication and different devices depending again from the indication. And with this one, I really thank you.
So Roberta, thank you very much for this very, very nice presentation. You really showed us how to treat upper GI lesions. Really excellent. I think we are all impressed. And I again want to motivate the audience to ask questions in the Q&A section. So there is one question from the audience. I think it's to Erik. So he congratulates for the great talk and asks if there is a training program available for chromoendoscopy, how to learn chromoendoscopy. What would you suggest?
Yeah, I suggest, I am not familiar with a specific training program, but there is for Barrett's, there is a training program online. I don't know the name, but by heart. For the moment, but you can probably find it. And
the Born program.
Sorry, the Born program. Yeah, Born program. Yeah.
And you can find it on the best academia website.
Yeah, correct. So you were involved in that as well. So there's the Born module, and yeah, there are a lot of cases. You can practice with finding lesions, at least in the Barrett's esophagus.
Okay.
Yeah, there's also the BLI portal. So I use it at the beginning of my experience with BLI. It works very well.
Yeah, I think there are different portals where you can learn, and I think you have to use it in your daily practice. I think that's very important. And as you said, Erik, make images and then compare it with histology, and that's how you can really learn from in daily practice also.
Absolutely.
Yeah. So Roberta, you showed us cold snare in the duodenum. How is your experience with that? Do you use it very often, or do you usually use them hot?
You know that I'm lucky because I'm working in a reference center for a lot of diseases and mainly for duodenum, and they are sending us all those lesions from all Italy. because it's difficult to treat them. Really, they have a high risk of perforation, even delayed perforation. So you think that you've done the best of your work, you haven't touched at all the muscle layer, but then for those thermal injuries, you have a delayed perforation. So we start some months ago to apply this technique that is injecting and then cold, because injection makes you clear the margin, and even to be more able to catch the pieces with the snare. And then we do all of them cold, and we are having great results, really.
Yeah.
Because of the bleeding in the duodenum, Roberta, do you use Purastat in all the duodenum?
Not in all of them, so it depends on the size, honestly. But let's say there is a big one, more than 3 centimeters, will apply for sure. And even if patient has to take back anticoagulants or antiplatelets, so it depends on the case. I mean, most of the case we are applying the Purastat later.
And are you injecting with adrenaline solution, or?
Yes, a little bit, but the adrenaline is just for us. It's not for the patient, honestly.
I think so. I think so. Okay, there was one question for you, Roberta. What type of cap do you use for ESD?
Yeah, I showed 2 different ESD. One was with this ST hood, that is this conic shaped, that really helps you enter in the submucosal space very easily, or you can use a standard cap. So it really depends on you. The fact is that that's not the perfect device ever, so it depends really on what you used to, what you are familiar with. But this ST hood is really working well.
Yeah. Another question was, what do you think about closure of those wounds after ESD or EMR? Do you do it usually, or what is your approach?
Usually don't. In the upper GI, don't close it. In the esophagus, because it will create stenosis, and you know that our enemy is the stenosis after ESD in the esophagus. In the gastric side also, because there's no risk. What's the reason to close it? To prevent perforation or to prevent bleeding? So if it's for bleeding, we have different things that we have to do, like, for example, Purastat, but at the end of the ESD, for example, go in and check for all the singles vessel, visible vessel, and try to regulate them. So there's no reason really to close it. In the duodenum, really, it depends. If it's a really wide one, and if it's possible to close it, because it's not always possible with standard clips, maybe we should try, but it's not really working every time.
Yeah, totally agree. And it could be very cumbersome to close in the duodenum, and you might induce a perforation with the clips. Exactly. So I would be very careful.
Yeah.
Ed, you have a question?
I just want to congratulate Roberta on a fantastic talk, and thank you, Erik. Couple of comments really about Purastat. I like that. We always have nightmares in the duodenum. It's the nightmare scenario. I always, keep my phone by the bed just in case they bleed. So I think Purastat is a good idea, albeit it's not proven yet. We need more data, possibly because of digestion relating to the pancreatic juices, etc., being a protein. And I'm also really interested in the Manta needle that you showed. It looked really cool, and I think it improves injection. I haven't used it in my practice, but I'm keen to use it. My question mainly relates to your methodology of ESD. We always mix.
I don't know if as a panelist you are allowed to make questions to me, honestly, Ed.
I'll still ask you. I'm going to take it with Ollie's permission. So, a question: when you're applying the different modalities, you showed us string, you showed us, with the ST hood, the pocket creation method of Professor Yamamoto. He developed it, modified by Yutaka Saito, as you know. Do you ever use the saline jet to try to help you lift the submucosal space?
The saline jet, what is it?
Saline jet, so a water jet to try to lift the submucosal space to get you in properly. Do you ever shoot?
You mean the standard water pump?
Yes. So it helps to lift sometimes. We put saline inside the conduction.
Yeah, I do both through the flash knife, but also with a water pump. This is mandatory to perform ESD with a water jet scope. And you know that FUJIFILM, all of them, all the new series scopes that have a water jet function, that is exceptional. Not all the other brands are like this. So it is really mandatory. So you use both. You know, I'm not aligned this one because it's so usual to me, so familiar to me that I'm doing without highlighting. So it's normal. Yes, definitely.
For the audience, it's good to bring it out. Thank you so much.
No, thank you.
Okay, Ed, no more questions because we need some time for your talk. So Ed,
good.
Please tell us about the buried bumper syndrome.
Thank you so much. So I'll speed through it. I know we're conscious of time, and mine is a small talk about a problem, which fortunately is not a very common problem, but when it happens, we all get a headache. You know how much a big of a headache it can be, buried bumper. These are my disclosures. So it essentially describes when internal fixation of the PEG plastic thing, which is known as the bumper, migrates into the gastrostomy tract. And then subsequently, what happens is that you get granulation tissue growing over it. And there's several ways of describing it, as we all know, with classifications, mainly on radiological imaging. But this can be complete, meaning that there's no exit port left, or else it can be partial. And of course, the complete buried bumper can be an absolute nightmare to deal with and sometimes may warrant surgery. But as paladins for minimally invasive care, us endoscopists, we strive to deliver away from the surgical scenario. And this is what my talk will be about. We have theories about this process, why it happens, and we think that it is relative ischemia, which then induces the production of granulation tissue. And as I say, fortunately, the incidence isn't that common. It's up to 4% as described in our recent guideline, which I advise you or entice you to read, the ESGE guideline. This is it. This is part 2, dealing with complications. Part 1 deals with all other aspects. And we also mentioned the device that is going to be central to our talk today. And how do we prevent it? We also give advice on how to prevent it. And the common thing is that after the PEG site has healed, so we leave it for about 2 weeks to heal, then we encourage mobilization. And this is part of good practice. You know, you have to release the PEG fixation and push the tube in and rotate just to make sure that it isn't catching. And if there's any beginning of catching, this will be disrupted and buried bumper syndrome may be reduced. There's not much evidence to prove this, but it's a strong recommendation from our society. So what are the signs and the symptoms? Of course, when you try to mobilize it, if it's stuck, it can't rotate, it can't be pushed forward, and the patient may describe abdominal pain. And abdominal pain may be a harbinger of complications. And the complications are, of course, abscess formation, because, you know, the feed gets entrapped in that little sac created by the granulation tissue, which then is a very fertile ground for bacteria to form, and you get an abscess formation which manifests with seepage of purulent mucus, and then subsequently this may evolve to rampant sepsis with unfavorable outcomes for the patient. And if it is complete buried bumper, then of course you can get feeding failure, mainly due to the blockage of the outflow. Definitive diagnosis is usually done by cross-section imaging, and in here you see this granulation tissue covering the PEG bumper, and this is, yes, a complete buried bumper. So the management depends on the scenario. If blockage or infection is present, it warrants intervention. If it's incomplete, you may get away with it, especially in an elderly, frail patient. But if there are circumstances where the patient is at risk, we need to intervene. The question is how to intervene, because there's no real standardized strategy. People have used needle knives, ESD knives, sphincterotome. We've even published on this recently with my colleague Nikolaos Lazaridis being first author in 2019 on a multimodality approach using all the above plus balloons and pushing and using a T type of technique where the snare grips the bumper and you pull it towards you, and the combination of all the above. But of course, these are all off-label and we're using them off license. So FUJIFILM, MedWork in the first instance, which was then, as you know, taken over by FUJIFILM, and it's growing proportionately and significantly, have developed a dedicated single device, the Flamingo set. And I really like the name and the artistry about it, because it goes to show that these people have a creative twist, and the creative twist is good in the development of future technologies. And they called it Flamingo set just because the shape mimics the neck of this beautiful bird we call the flamingo. And as you can see, it is like a sphincterotome, but it has advantages. It is much stiffer and it has more control than a sphincterotome. Remember that a sphincterotome has already been used for the resection of buried bumper, but this is developed with buried bumper in mind. How good is that? This is the device. It's a sheath that has a guide wire that allows for its introduction. This is a virtual peg bumper to show how this guide wire here, when activated through the handle, and I'll show you where it connects to the diathermy, is able to cut through tissue directly on the bumper, and the bumper itself protects against perforation. And of course, it can open and close its neck, or like the bird, flex and extend its neck, and it can rotate, of course, to manage the situation accordingly, and I'll show you how. Intuitively, of course, the set, that's why it's called a set, contains a guide wire to allow introduction, and also a grasping forceps in order to retrieve the peg bumper and the peg remnant once it has been removed. And this is the all-important handle. It's got a channel where you can introduce the guide wire, of course, critical for its introduction. And this is where the diathermy attaches, okay? And I'll show you how it works. So in essence, we are looking at the flamingo and the buried bumper from an endoscopic standpoint here. So this is outside the body and this is inside the body. And it needs two operators or an assistance. And one of the operators is actually applying some traction in order to get the guide wire, the bowstring rather, wire in contact with the peg bumper. And when the diathermy is activated along with a bit of traction from the outside, you make a cut and then you move the flamingo to oppose the next bit of tissue to make continuous radial cuts like a star, and so on and so forth. And eventually, once you see the plastic coming through, you push forward and bingo, you've got your bumper. And then you just retrieve it with a grasping forceps and out you go. And these are the diathermic settings for the 200D, the Vial 200D, and their equivalents. I'm sure the company will tell you about them for the new Vial 3. So I'll show you an illustrative case which we published in Video GIE. A plug here for Video GIE. Do submit your videos. We've revamped it. It's really cool, and we've got different sections now. So David, if you could start moving the little dots for me, if we could go back and move the little dots for the video, if you can play the video. So we'll jump through it just so that we will save on time. So this was a 94-year-old gentleman. You can see that there is a granulation tissue growing over the bumper, and we can move to the next marker after we've put through the guide wire. We then push through the flamingo set, and you can see the flamingo making the radial cuts and doing its job fantastically well. Next marker, and with radial cuts, eventually next marker, we're able to release the peg bumper. So you can jump to the next marker and then quick succession to the next one, so that will save on time. I know that we have been limited by time. So if we could jump to the next marker, please. You can already see it peeping through. The bumper itself is protecting against perforation, and you jump to the next marker and the next one, and bingo, voila, patient better released. This was an infected peg bumper, which would have had consequences. So what about studies? Apart from our video, there have been two publications. The original paper by Hendricks et al. From Belgium, which had 5 successful cases published in Endoscopy, and then spearheaded by Deborah Costa and Alberto from our group, Dr. Moreno, we managed to align the data from 15 centers in a retrospective multi-center cohort study, international cohort study from the UK, from Belgium, and also from the Czech Republic and Germany. And I'll run through this just because it is a useful understanding. So 55 patients, median age 66, 42, 76% of them were male, and you can see the range was really wide. And the PEGs were in situ for almost 2.5 years as a median duration. And successful removal was achieved in 96%. The median duration of the procedure was 22 minutes. Now, we all know that a buried bumper that's completely buried can actually eat up an hour plus of your time if it's successful, okay? So bringing it down to 22 minutes on average, on a medium rather, is a very good outcome indeed. We had to use additional devices, and we may, include these in future flamingo sets, possibly mainly a snare and plus or minus balloons in about 72.7% of cases, but that's acceptable, I think. As you know, when we use a multimodality approach, we have to use about 4 devices at least, okay? So this is a diagram showing the outcomes. So overall, we had a very high success rate. In 2, there was a failure. One of them was completely buried into the abdominal wall, so that's a big no-no. And the other one, there was a failure of the plastic sheet for some reason or another, but that's very rare. We had an adverse event rate of 12.7%, but these were all managed endoscopically, okay? And I'll give you a bit of perspective about interventional related adverse events for other modality approaches. So this was a very nice paper published from Germany and Brazil a few years ago. And I'll bring your focus onto the needle knife approach, where the complication rates were 45.5%, mainly due to bleeding, okay? So an acceptable complication rate for the flamingo. So in summary, ladies and gentlemen, friends, colleagues, Oliver, Erik, and Roberta, I hope I have shown you that the flamingo set is the first and only dedicated device which is efficient, safe, and effective. And I'd like to thank my colleagues, of course, especially Deborah, who's now working in Conegliano in Italy, and my dear friend and colleague Alberto, who spearheaded this study with Deborah, and of course, all my colleagues from the Royal Free. And I invite you to our Advanced Endoscopy Masterclass, which is to be held on the 5th to the 8th of September 2022, with 2 full days of hands-on with the best of the best, including Professor Yamamoto. Thank you.
So thank you very much, Ed, for this very, very nice presentation showing us the flamingo device. I think it really is a revolution for buried bumpers. So I use it all the time when we have a buried bumper, and it really works very, very well. So there are a few questions in the chat, but I think we have time only for 1 or 2. One question is, would you place a new peg after the removal of the buried bumper?
Very good question. So in our study, about half got a peg even through the same port. And there is no evidence to show that if you put a peg through the same port, you will get a buried bumper again. It's all about the aftercare. So as long as, I think, when you're removing a buried bumper, especially if you're suspicious of infection, do it with antibiotic cover, always, because those 2 cases of sepsis that we had later, which eventually recovered, hadn't had antibiotic cover. So do it with antibiotic cover. And as long as you do the aftercare properly, it doesn't mean that because you've had a buried bumper on that patient through the same site, you're going to have it again. It's all about the aftercare.
Mm-hmm. And how many days after PEG placement do we have to mobilize the PEG?
So I'd say after about 2 weeks, you give it some time to heal the track. There's not a hard and fast rule. It is not exact science. It's logical, because if you mobilize too early, you may dislodge and cause peritonitis. But as soon as the track has healed, then you start mobilizing and rotating. And that's very strict, important advice, especially for these patients who go back to nursing homes. We need to it is our duty to educate the people looking after these patients.
Okay, so I think we close now our webinar, our session. I think it was really, really exciting. Thank you very much to all the speakers. It was really great to learn about the different topics. So I want to, of course, announce the ESGE Days 2023. It will take place in Dublin, in the convention center there. That is must be very beautiful, and hopefully we can see you all there in 2023. You should, of course, become member of the ESGE. You have many benefits being a member. You get the endoscopy journal. You can attend ESGE Days with reduced registration fees. So please apply for membership. And so also you have a reduced cost for the dual membership program with your local membership with your society and the ESGE, and then you have the reduced costs. So the next webinar after the summer break will be in September the 7th. It's again a Wednesday, and it is also from Fuji, and it's from Diagnostic to Treatment and EndoSolutions for HPB. So thank you very much, everyone. Thank you for the ESGE team, and I wish you a great evening. Bye-bye.
Bye-bye.